All right, and for the first disease that I'm going to cover, let's talk about atopic dermatitis. Now, you might have heard this called eczema, which is much more common, but at least in a more professional setting, the term atopic dermatitis seems to be a little bit more favored because it really emphasizes its connection to a lot of other atopic conditions. And something we're sort of understanding is that a lot of these, pathologies that we thought were very distinct are more and more revealed to be quite related, not only mechanistically, but just epidemiologically as well. So a lot of people who have some are predisposed to have others as well. And that's why the name atopic dermatitis is sort of starting to emerge. So for a lot of these case studies, we're going to, sort of follow a general format, which is I'll give it a little bit of establishing information, might talk about some epidemiology or risk factors. Then we'll dive into both the clinical side and the sort of biologic or mechanistic side as well, and then wrap up with some management and therapeutics. So as far as atopic dermatitis goes, there is a genetic basis to it. However, it is not very well understood and it's pretty expansive. So you can see in this image here, these are just some of the genes that are sort of have been identified through, association scans or other mechanisms that might have something to do with predisposing you to atopic dermatitis. But sort of the unifying factor here, at least on a big picture scale, is that the most involved genes are going to be directly related to how your skin barrier works. So let's talk a little bit about that. So one gene I want to bring up is the flagrin gene. So this encodes a pretty major epidermal barrier protein called flagrin. And if you're homozygous for this mutation, not only are you very likely to have early onset atopic dermatitis, but it's going to be much more severe as well. And if you contrast that to someone who's heterozygous for this FLG mutation, we see that those patients have much higher chances of outgrowing atopic dermatitis. This is a really cool, it's not always this sort of clear cut, but it's really cool to see that this gene is a pretty strong indicator of atopic dermatitis severity and sort of onset. There's other genes as well. So this claudin gene, CLDN1, encodes tight junction proteins, which are important again for maintaining that sort of barrier between cells. We see this is also dysfunctional in atopic dermatitis patients. And we also have another one I want to mention, which is SPINK5. So this is more of an involved pathway, but essentially this is an epidermal gene and it encodes this inhibitor. So this inhibitor shuts off serine proteases. But if we don't have this inhibitor, if we have this mutation, we're going to have a lot of serine proteases that are going to be just running rampant in our epidermis, and this is going to cause excess inflammation, desquamation, just a general deterioration of the skin barrier. So as far as diagnosing atopic dermatitis in the clinic, well, you're going to look for various, major features. However, there aren't really any specific lesions or laboratory parameters that tell you definitively this patient has atopic dermatitis. So whereas, smallpox, you might have that really specific, pustule. In atopic dermatitis, the manifestations are much more variable. So we basically look at certain clinical features that are classified as major or minor, and then we combine those with more quantitized measures such as the SCORAD, which stands for Severity Scoring of Atopic Dermatitis, and the Eczema Area and Severity Index, which you can see up here. Let's talk a little bit about those clinical features. So the major features are going to include itching, and specifically we're going to look for involvement in certain areas. So in children and infants, we're going to look for facial and extensor involvement, so things that are sort of extending out and moving. We're going to look for a family history of atopic diseases. We're going to look for this thing called flexural lichenification in older patients. And this is sort of a thickened, leathery type skin that starts to form and is suggestive of atopic dermatitis. And other features we might look for, here's a bunch of new words that I learned when making this. We have xerosis, which is just dryness and scaling. We have keratosis pilaris, which is this top image here, where you see these tiny red dots that are basically keratin deposits in the skin. We have pityriasis alba, which is light, these sort of light patches on the skin you can see in this bottom image. And we also have things like serum IgE tends to be elevated. We have, cutaneous infections are more prevalent because your skin barrier is broken down. We have things like positive allergy tests, which again suggests sort of an underlying atopic inflammation that might also be present here. So we can sort of classify atopic dermatitis as either acute or chronic. Now, acute is going to be a really sort of punctuated episode. You're going to get itching, these papules. You might get bleeding, fluid leakage. You might start, creating these self-created sores called excoriations. So that's sort of on the left side. You can see it's really flaring up. The skin is heavily breaking down. And we can contrast that with chronic atopic dermatitis, which is more of a just leathery skin. So it's that lichenification, just the thickened skin. And this is sort of more long-term, so it's not an acute episode to say. So we could talk about some complications that happen with atopic dermatitis in addition to the general symptoms as well. So because atopic dermatitis patients tend to have increased sort of just general inflammation, that includes also a lot of Langerhans cells that are sort of going crazy in the skin near the eye, specifically in the epithelium called the conjunctival epithelium. So when your inflammation is really concentrated in that area, you can get atopic keratoconjunctivitis. That's a bit of a mouthful. And this involves a lot of these same symptoms of atopic dermatitis, but it's really concentrated in this area up here. And now, as I was saying, because your skin barrier is just generally broken down, of course, you're going to have a lot of pathogens, invaders, bacteria that are able to get in and colonize or replicate that normally would be kept out. So due to this, we see a lot of infections that are exacerbated in atopic dermatitis patients. And for one, herpes is a big one, and it's sort of a big enough deal that people who have atopic dermatitis and herpes, at the same time, have a specific condition that is referred to as eczema herpeticum. And that just basically is a term to describe all of the worsened symptoms that arise when these two things are starting to mix. And now this is sort of getting into more of the mechanism side of things, but again, I just want to highlight that atopic dermatitis is really about the barrier dysfunction. And with a barrier dysfunction, we see a lot of things. We see you, losing water, which is a big one. That's why you get that dry skin. And again, that goes back to things like having less flagrin, having less tight junctions, having higher levels of these proteases on your skin. But it could also be things that are not genetic. For example, if you're someone who uses a lot of soap, that could be stripping a lot of the lipids from your skin that are actually there to keep the moisture in. And this is why people with these conditions might have to seek out very specific products. All right, and this is sort of going to more of the pathogenesis, but we might wonder, why are these patients having these high levels of inflammation? What's the root cause? Well, this slide doesn't necessarily answer that, but it shows us things that are sort of out of whack in patients with atopic dermatitis. So we see things like increased levels of IgE, so that's going to have a whole sort of cascade effect in causing more degranulation by inflammatory cells, more pro-inflammatory cytokines being released, all of those sorts of things that can sort of sustain inflammation. And the next question might be, well, if we have this prolonged inflammation, why is it not going down? Why do we not have, or why are all of our body's mechanisms to tone down inflammation not working? And that just might be because, as you can see here, that a lot of the T regulatory cells in atopic dermatitis patients just aren't really doing the job that they need to do. So really just not having that immunosuppressive effect is really a cherry on top to already all of the extra inflammation that's being caused by all of these pro-inflammatory cytokines, increased IgE synthesis, and things like that. So this slide basically shows some more things that might be going on immunologically in a patient with atopic dermatitis. So the first thing I want to point out is that these Langerhans cells and keratinocytes in the skin are going to be secreting pro-inflammatory cytokines like IL-1 and TNF-alpha. These are going to upregulate expression of the E-selectin protein, which allows more memory T cells to bind. So that's just a way in which some of the local cells can begin recruiting some of the more distal cells to these sites of inflammation, specifically at these atopic dermatitis lesions. We also have things like eosinophils here that are going to be degranulating constantly. Something that's interesting is we actually see a lack of polymorphonuclear neutrophils. So these are cells that are typically helpful in fighting off invaders. And if we have lower levels of these, it would make sense that in addition to the broken skin barrier, these atopic dermatitis patients are going to have increased levels of infection. And another thing that I want to sort of tack on at the end here is that, interestingly, keratinocyte apoptosis is increased. And that might seem a little counterintuitive at first, because this first point says that they are the ones that are helping to recruit inflammation in the first place. But what I want to point out is that a lot of those scales that form on the skin of atopic dermatitis patients are actually comprised of dead keratinocytes. So having an increased level of their shedding is going to contribute to that the formation of that leathery skin. So let's talk about one symptom in specific, probably the main symptom, and that is pruritus. Pruritus is a fancy way of saying itching, but here's how it sort of works on a bird's eye view level. So the first thing we notice is that IL-31 is going to be one of the cytokines that is directly responsible for that itching. We also see that TSLP is released from these keratinocytes, and importantly, this is what I want to point out, they can act directly on sensory neurons that sort of start to initiate that itching sensation. So the big point here is that, it's not just chemical, it's also nervous. So whenever we think of a symptom like itching or sneezing or coughing, we always have to think about how the immune system is going to connect to the nervous system, and TSLP is one of the bridges there. But overall, we can think of a sort of itch-scratch cycle that connects the two constantly. So you scratch your skin, that causes these inflammatory cytokines to be released from keratinocytes. More immune cells are going to come, and that's going to sustain the inflammation. So it's really a cycle, and you can see that over here over and over. One interesting thing is that histamine isn't really as central to atopic dermatitis itching as you might think, which is interesting because we think of histamine being really central to hives and urticaria, but it's interesting that it's sort of distinct in this case. All right, so how is atopic dermatitis actually managed? Well, I would sort of split it up into 3 layers, one of which, this one is sort of the most boring, but arguably the most important, which is just to avoid irritants, to avoid triggers that exacerbate it. So this is something that, you would know when you're diagnosed. Are you really sensitive to things like chemicals or temperature, things like that. So really avoiding the things that make it worse is going to always be the first step. The second step is a little more active. So this is, again, going back to the fact that atopic dermatitis really roots itself in barrier dysfunction. And because of that barrier dysfunction, we're losing water, transepidermal water loss. So all of these methods are going to be necessary to sort of retain water, and those include using emollients, using very hydrating substances, and then coating with a layer of lipids, that sort of thing. But the final level, which is sort of the most severe, is going to be using a pharmaceutical intervention. So let's talk about that. The most common one is going to be using some form of steroids. So these help reduce inflammation, they reduce itching, and they come in various sort of strengths. And we see that they actually also help sort of either have some antimicrobial properties or some barrier restoring properties, because we see that in atopic dermatitis patients, levels of sort of bacterial colonization also tend to go down. But they might not work for a variety of reasons. One of those might be that chronic atopic dermatitis patients just might have a lower affinity for these steroids to bind. We have patients that, might not be fully compliant. A lot of people are scared about steroids. And some people's T cells just might not be as responsive. So the last thing I want to talk about is actually a biologic agent. So this is more, a very, very severe treatment that you would use in patients with quite uncontrolled atopic dermatitis. But this is dupilumab or Dupixent, and it's a monoclonal antibody that works to shut down IL-4 and IL-13 signaling, which, remember, those are sort of perpetuating a lot of atopic inflammation. They're perpetuating the itch-scratch cycle. And the way that we do that is that you will target the alpha subunit of the IL-4 receptor. And that is actually shared between both of the cytokines. So by targeting that receptor, you can shut down signaling of two cytokines at once. So it's been pretty promising. It's already approved in Europe for adults that have moderate to severe atopic dermatitis, and most of these patients, after a few months of taking the medication, saw a pretty dramatic improvement in their EASI score, which is again one of those more standardized ways of measuring atopic dermatitis severity and area. We see things like reduction in symptoms of itching, improved quality of life overall, and also just less anxiety and depression regarding atopic dermatitis, which isn't something that I fully got into in this presentation, but there is a huge mental health component surrounding eczema and atopic dermatitis, not only because of the way that it affects your outward presentation and your perception of self, but also the whole itch scratch cycle can be very intertwined with people who might have addictive personalities, or who might use that as a means of stress relief. So that's something I wanted to leave in there, just to gesture to a sort of larger picture that I didn't get to address. But that sort of wraps it up for this presentation, and I hope you learned something.